Hello everybody, this is DAROGA video 47 and 48 about shoulder dystocia, an important topic where the management can determine a good outcome for the baby and the mother, and if not, there might be permanent damage and even fetal demise. Where have we been hiding over the last few months? Well, let me tell you, Jimmy and myself and my wife, we went to the lovely Eyre Peninsula in the western part of South Australia. Here you see a picture of the rugged coastal line and really spectacular to relax and unwind. Shoulder dystocia. Part 1, I will discuss the background, the definitions, the risk factors, the root cause and the management with a number of external maneuvers. Hopefully, as always, DAROGA can contribute that a topic changes from cloudy in your mind to clear in your mind. And moreover, that you are more confident and caring clinicians to be. Part 1 discusses the background, the definition, the risk factors, the cause of the shoulder dystocia, and based on that, the management with a number of external maneuvers. In part 2, we will discuss management if the external maneuvers have failed and we need to revert to more invasive measures. And of course, we will discuss complications. How important is this topic? Well, you could argue it doesn't occur very often, on average 5 in 1,000 deliveries, but it depends as well where you work. We know that it's essential that you know how to manage this situation, this complication, as a team. It's not about the doctor only, but it's about the team. Risk factors. As you might have understood, I'm not in favor of learning risk factors by heart. It's probably good to know a few for your exam. But here, maternal risk factors. Diabetes, obesity, multiparity. For the fetus, if the estimated fetal weight is more than 4 or 4.5 kilos, and we know it's hard to estimate the fetal weight antenatally, if there is a history of a large infant or shoulder dystocia, the risk of recurrence is of course higher. And the delivery, during delivery, if there is a prolonged second stage of labor, after a mid-pelvic instrumental delivery, so ventouse or forceps delivery, and of course, if there's a combination of the aforementioned factors. The majority of cases, however, occurs out of the blue in a woman without any risk factors. So the conclusion is very simple. Shoulder dystocia is in principle unpredictable and largely unpreventable. That's why we need to be prepared 24 hours a day, 7 days a week, and 356 days in a year. What is required for the diagnosis? It's a clinical assessment, is basically using your eyes only. The cardinal signs are: 1, there is a difficulty with delivery of the face and the chin of the baby, so it's so tight that the face and the chin don't appear over the perineum. The so-called turtle sign. The head remains tightly applied to the vulva, and sometimes even outside the contraction and outside pushing, the head even retracts a little bit. That's why it's called the turtle sign. Here you see the turtle's neck is not stuck out and it's slightly inward. That's why I think it's a nice, it's like a cute description. Here you see the little turtle face to face. Another sign could be failure of restitution of the fetal head. That means usually the head should rotate as soon as it's outside the maternal body from the OA position, so 12 o'clock, to either ROT or LOT. So the baby's head should rotate back to the right hand side or the left hand side. If gentle downward traction has failed to deliver the anterior shoulder, well, that's another sign. So refer to the physiology of the second stage of labor and the cardinal movements in the DAROGA video as I pointed out here. What is the challenge and the solution? 1. Call for help. Don't be stubborn, don't be cocky, but ask for other people to come and give you a hand. Team involvement is essential. First, you need to have the most experienced obstetrician or obstetrical registrar or duty registrar who knows what maneuvers to apply when. And we like to have on standby the anaesthetist in case we have to do a crash cesarean section under GA for the so-called Caravanning maneuver. More about that later. And we want to have a pediatrician standby if need be to resuscitate the baby if there's a low EPCA score. And of course, there's no rush, but we want the pediatrician to assess for any complications such as fractures or nerve damage. The doctor as team leader needs to know what steps to take and in what order, how and how long to perform each maneuver externally and internally, whilst maintaining effective communication. Very important. It's essential to keep the mother, her partner and family involved and to explain what you're doing and why. This means multitasking under pressure. Well, multitasking doesn't really exist, but it's quickly shifting from one task to the other, doing the maneuvers, asking for help, instructing your team, and friendly communicating with the family members and the mother. What is the nature of the problem? I cannot stress enough, this is essential to understand, because if you understand the underlying mechanism, all the tricks we might present later on make sense. The anterior shoulder is stuck behind and on top of the pubic bone, and the posterior shoulder is stuck behind and on top of the sacral promontory. So, bony misery. The bisacromial diameter is stuck in the anterior-posterior position, to say it in a more medically appropriate way. Well, here's a diagram. This diagram is nice but not perfect. We can see here the anterior shoulder of the baby. This is the symphysis pubis. This is the sacral promontory here. And the shoulder actually is in this plane. The shoulder here is already beyond the pelvic inlet. So this diagram is not perfect, but it's reasonable to explain. So the shoulders are stuck where you can see the red arrow. When you look at the bony pelvis, here is where the shoulders are stuck in the anterior posterior diameter. So, very disappointing maybe if you are a fan of evidence-based medicine, like DAROGA, but there is no high level evidence. There's no randomized clinical trial for obvious reasons. If there is an emergency, it's hard to obtain informed consent, do the randomization, etc. But anyway, we have case reports, case series, and some prospective and retrospective cohort studies. But mainly it's pragmatic approach, it's common sense. And that's not bad. Let's say there is no randomized clinical trial to demonstrate to friend and foe that jumping out of an airplane is safer when you use a parachute. Well, we all know that common sense prevails in this example. This is really what I would refer to as the art of obstetrics. Understand the root cause of the problem, then develop the dexterity and the skills to resolve the problem. That requires mechanical thinking, but also develop the attitude, if you don't have it by nature, to manage your own emotions, your own adrenaline gush. I can tell you that happens very regularly if you call in an emergency. But you stay externally very calm and professional. Always. There is no excuse. By the way, I think we are human beings and it's perfectly right to curse internally and use maybe some colorectal jargon, but internally. Utter it between your vocal cords and your esophagus and keep on smiling. Very popular is the so-called HELPERR mnemonic. It divides the different approaches in a number of basic approaches or maneuvers and a number of advanced maneuvers, as you can see here. I would like to present this very popular mnemonic, and it helps us to approach the situation in a systematic way, not only clear for ourselves but also for our team members. Basic, call for help, consider to perform an episiotomy, the E of episiotomy, the L of legs, flex the hips, that means the external maneuver referred to McRoberts. 4 is pubic pressure, external maneuver called Rubin I. Then advanced maneuvers, there are 3 internal maneuvers which require that your fingers and hands enter the maternal pelvis. Another basic maneuver which everybody should be able to apply is turn the mother on all fours. Rotate on all fours, the R of rotate. And the last one is remove the posterior arm. It sounds a little bit aggressive, but it's not really removing the posterior arm, it's actually making sure that the posterior arm is delivered, so it's coming down in the pelvis. I'll go through all these steps systematically, and at the end I will show that this HELPERR mnemonic is not ideal, in my honest opinion. So basic part 1 means this is what every midwifery, nursing and medical student should know, and junior doctors. The advanced skills and approaches I will refer to and discuss in part 2. Those are essential for future midwife, future doctors and clinicians supporting women in labor and delivery. Mayhem. This is a scary looking Norwegian black metal band called Mayhem. The chap to the left is called Euronymous, the one in the middle is Dead, and the one to the right is Necrobutcher. I think they stole this a little bit off Kiss, but anyway, I will discuss Kiss towards the end of my lecture. Mayhem means panic. Oh my goodness, what's happening? We should be able to learn to confidently, by training and practicing, and calmly manage the whole situation. Give clear-cut instructions to your team members. I am advocating for cockpit communication, which means you might ask from one of the midwives, please call the duty anesthetist, and the midwife replies, yes, Alphonse, I will call the duty anesthetist. That means that everybody in the room knows we do not have to ask for the anesthetist to arrive. So this is an essential part of the communication. So not replying with yes or no or roger or understood, repeat the message back. Keep explaining to the mother always. Form what I would call a joint venture with her. That builds trust and that will without doubt contribute to a better outcome. Support the mother during the event but also afterwards. Sometimes after a very challenging shoulder dystocia, for us the adrenaline gush has gone, we have a nice cup of coffee and that's it. But for the mother, she might still be laying in her bed with a baby with a fractured humerus, for instance, and she might have the feeling that she failed. And the risk that she develops postnatal depression or post-traumatic stress syndrome with issues with her own mindset, but also with bonding of the baby is considerable. So we have the moral and professional duty to look after her as long as required. Keep that in mind, essential. Okay, the first part of the HELPERR mnemonic is the help. Call for help, the senior obstetrician or the obstetrical registrar or the duty registrar, the duty anesthetist in case we need to do a crash cesarean section, a pediatrician to prepare for a potentially flat baby, which might need some resuscitation. At this stage, we should ask the mother to stop pushing, because sometimes in a reflex everybody says keep on pushing. It has no use because the shoulders, the bones of the baby's shoulders are stuck to her pelvic bones and that defeats the purpose. Stopping to push will improve the perfusion of the placenta and the umbilical vessels, which means more oxygenation, so that's quite useful. Episiotomy, well, you can consider an episiotomy, but at this stage it's a bit too early. You're jumping the gun, because an episiotomy might be required when we are performing internal maneuvers. This is personally something I do not like about this mnemonic. It would be overly aggressive. Then the legs. Legs, the L stands for legs. Well, in fact, we encourage the mother to flex and abduct her hips. That's called the McRoberts maneuver. I personally dislike all these names because it's extra baggage for our hard disks in our skulls, which are already quite full, at least mine is. So explain to the mother, hey Lisa, the baby's shoulders are stuck, you need some help. So I would not ask for help, you need some help. You have to be kind and directed. I will call a few people to give me a hand. Position her correctly in bed. Initially, maybe that's not important, but later on you might want to put her in the stirrups, especially if you want to perform internal maneuvers. That's essential. So you have the room and also to protect your own back from bending forward all the time. Then we ask her to instruct, like in this diagram, put your knees to the nipples. That's an easy way to explain and maybe better to understand. Flex your hips. Secondly, if she can't do it because her legs are paralyzed because of a heavy epidural block, her partner or midwife can take a leg to perform this procedure, flexing and abduction of the hips. We like to perform each maneuver for 30 to 60 seconds. It's interesting because I have seen no evidence why 30 seconds is better or worse than 60 seconds, but I'm just now quoting what I've learned in the past, which is not always correct. This is the maneuver. At the same time, the accoucheur can continue with downward traction of the fetal head, and the mother can push now. It's also useful to appoint a timekeeper, because you lose track of time. Ask a person to write down what happened, when a person arrived or when a drug was administered. That is very useful, as we show later. Then the rationale of the McRoberts maneuver, it causes a significant rotation of the symphysis pubis and it results in flattening of the sacral promontory. Allegedly, it's effective in about half of the cases of shoulder dystocia. Well, the evidence is not very convincing, but this is what I've found in few publications. By the way, from now on I will use a number of beautiful three-dimensional diagrams which I copied from the book Obstetrische Interventions in Dutch. By the way, Dutch is the official language of the Netherlands. And I'm really thankful that the colleagues who produced this chapter, that is Professor Van den Berg at the University of Groningen and Professor Eyre in the Maxima Medisch Centrum in Veldhoven in the Netherlands, because these pictures, and I think the pictures were made especially by the Vincent Cow, these are very impressive and very useful to explain this so well. Here we see the mother position, abduction and flexion of the hips. The result is a reduced lumbosacral angle, as you can see beautifully in that diagram. The angle here before the flexion is bigger than the ones it has now straightened out, so there is more room at the level of the pelvic inlet posteriorly. So essential that the supra-pubic pressure, that is the maneuver which follows if the first one fails, we are performing supra-pubic pressure, also called Rubin I. The pressure should be applied above the pubic bone, sideways, diagonally. We want either the anterior shoulder to move into the oblique, away from the symphysis pubis where there is more space, or we want to reduce the diameter between both shoulders by adduction of the fetal shoulders. Here we see a system diagrammatically. Note the fetal position, the head, the posterior fontanelle is on the left hand side, so this baby is LOT, so the person who does the Rubin I maneuver stands on the left hand side of the mother, and here we see the shoulder, the little black hump here, and is pushing sideways. This is how we should put pressure sideways, and we can do it in two ways, either continuously or intermittently in a rocking way, comparable with what you do when you give CPR on the chest. Here we see what happens if we perform suprapubic pressure sideways. The shoulders move away from the pubic bone and we can see now there is a little space and that is sufficient to solve the shoulder dystocia. Again, 30 to 60 seconds, continuous or in a rocking, or using a rocking movement, and the accoucheur, the one who is delivering the baby, can still pull gently following the pelvic axis. Here we see the diagram of the book Obstetrische Interventies, and we can see the hand actually pushing at the level of the scapula of the baby sideways. You see the blue arrow, so this baby's shoulders will make a counterclockwise movement. This concludes part 1 of shoulder dystocia. Thank you for listening and viewing. And as always, you see Jimmy here in the Southern Ocean on a hot day. It's time to cool down. It's important that everybody looks after his or her work-life balance. Whether you are a junior, senior student, an RMO, a registrar or consultant, work-life balance is essential. Thank you so much.